Good morning, everyone. My name's Richard Pugh. I'm an intensive care consultant based in North Wales. And rather ambitiously, I'm going to be presenting a talk entitled Who Needs Critical Care and How Can Critical Care Evolve to Meet the Future Needs of the Welsh Population. I'm presenting on behalf of a wide range of collaborators that you can see there. And in particular, I want to highlight among the funding streams for this work are that we have had considerable support from national strategic critical care bodies, but also from Health and Care Research Wales. In line with the overall theme of this morning's session, the things I wanted to cover over the next sort of 15 minutes or so are essentially what our existing routine data collection processes are, how we've developed an integrated critical care data platform, and how this extends existing routine data collection process. I'm going to provide a little bit of context with regards to Welsh Critical Care Services, the potential vulnerabilities and opportunities that they're in. I'm going to provide some examples of work we've undertaken to inform national strategy and service development and an indication of future directions as well, all in 15 minutes. Okay, so just to provide a little bit of background, we've good data to suggest already that the demand for critical care services is increasing of the order of 4 to 5% per year because of demographic changes, because of the chronic illnesses and morbidities that go with an aging population, but also because of changing perceptions about what critical care can actually offer, and of course, new and emerging diseases and treatment. And I'm presenting this obviously within the few weeks where the COVID inquiry visits Wales, and there's been sort of recent television dramas on the topic. To put critical care into context, if you rewind a decade or so ago, the United Kingdom as a whole was probably about 3/4 of the way down the European league table of critical care provision in terms of number of beds per 100,000 population, and Wales, according to more recent data, doesn't fare quite as well as this UK figure from a decade ago, and there is significant variability between health boards in terms of critical care provision. So this is the context, this is the background. It's important that we use the resource we have to the best of our abilities, but also if we're going to develop services, we need to target resource to where they're going to be most effective. So with that in mind, I'd like to almost start at the end really with describing an integrated methodology which brings together existing critical care data sets with other relevant data sets to inform where critical illness fits into a wider trajectory really. And critical care is an environment which is data rich. The 13 critical care units around Wales collect a routine data set which is essentially sent along two streams, one within Wales through Digital Health and Care Wales, which is very largely operationally focused, including demographic data, admission and discharge dates, and some organ support data. And there is a richer data set, which includes clinical data, which enables us to estimate the severity of acute illness, which goes to the Intensive Care National Audit Research Centre, along with similar data from England and Northern Ireland to the IGNAR Centre in London, which provides benchmarking and the availability for supportive research as well. So it's already data rich, but it's restricted to hospital admission stays. It doesn't capture pre-acute illness, post-acute illness, and it historically at least was limited in the ways in which you might capture chronic illness and frailty, which we will discuss in a little bit of detail, which is something that resonates hugely with critical care clinicians. So hugely grateful to Rowan Griffiths, who's recently retired, but has done some excellent work integrating the IGNAR data and the critical care data set, which historically was maintained and managed within Wales, integrating that with Office of National Statistics Death Register, some hospital admission data, PEDS, Patient Episodes Database for Wales, and with primary care data, the Welsh Longitudinal General Practice data set, among others. And in the interest of time, I'm not going to explore in any more detail how the integrated process has actually taken place, but I'll summarise some of the recent outputs of this work, which is essentially to say that fortunately there's a good overlap between the data that is submitted to ICNARC and the data that is managed locally within Wales through the critical care data set, whether you look at that in terms of admissions or discrete sort of patients. It provides a bit of oversight in terms of, to give you a flavour over a 10-year period. The majority of the patients that come to critical care are in the age cohort 61 to 70 or 71 to 80. And a consistent theme is that there are more men in intensive care than women by a ratio of 55 to 45. And that's a consistent finding for our data, but in the wider literature as well. Most patients who come to critical care during a hospital stay will only be admitted once, but there is a sizable proportion that are readmitted. And the data platform that Rena's been able to put together starts to illustrate the fact that we can look at data beyond the initial 2-week period following ICU admission through to 1 year and beyond. And it's some of those aspects that I'm going to explore more fully just now. We started to look at 1-year outcomes following critical illness, looking at patient level factors and care processes that might be important. We didn't have the full range of data available when we carried out this work. We didn't have the ICNARC data to inform us about illness severity. But we looked at mortality data at 30 days and at 90 days and at 1 year. I won't explore the process by which we landed at our number of patient episodes in any detail in the interest of time, but we looked at over 40,000 patient episodes. Historically, as I say, we haven't really been able to recognise chronic illness within our historic data, routine data analyses, but we utilised, in this case, modified Cholson comorbidity index based upon inpatient data for the previous year. And what we found that was that among patients that had survived their critical care stay, so their ICU survivors, about 20% had died within a year. There were non-modifiable factors that were relevant, and as you'd expect, age and comorbidity and indices of deprivation. There were factors that related to the presentation, an acute admission, medical diagnosis, admission from the ward, a longer ICU stay, more organ support as you'd expect. But we also noted that there were some process factors that were relevant as well, whether a patient had been discharged overnight or whether their discharge from critical care had been sort of hurried, had been expedited. We also started to notice that there were variations in one year mortality by geography. And some of these factors, some of this may be related to comorbidity, we conjectured, some of it may be related to variation in indices of deprivation. But we also suspected that some of it might be due to critical care capacity. And this resonated a little bit when we came across similar data reported from Scotland that suggested that with time there had been an increased variation in admission criteria and admissions to critical care according to age. So this led to our next piece of work, which was to look at admission trends over a 10-year period to investigate the patient characteristics there. And in addition to the previous data sets that I mentioned, we were keen that we reflected frailty within this. Although in practice, increasingly we're applying an assessment of frailty using the clinical frailty scale, the ability to be able to access administrative data to estimate frailty, we thought was very important for this exercise. And I realise that Professor Clwyd will explore this in more detail later, but just to flash that frailty, according to this administrative data, can be summarised as fit, mildly, moderately, or severely frail. Now, interesting, over this study period, critical care capacity actually decreased from a starting point of 178 beds to 167 beds, whereas the national population grew by about 5% overall, but grew particularly amongst the over 65s. And therefore, unsurprisingly, what we saw was a relative decrease in admissions to critical care over this time per capita of about 5%. But this was particularly prominent rather within the over 65s and the over 80s. We saw a decrease in proportions of our admissions with high comorbidity and an increase in proportions of older patients that we might consider fit. We saw some trends that suggested we were increasingly admitting surgical patients, and we saw a significant decrease in medical admissions among oldest groups. And this was interesting because we contrasted our work with what was taking place at the same time, reporting from England, Wales, and Northern Ireland as a larger whole, and admittedly over a longer period of time, but where there had been an increase in critical care capacity over a similar study period of about 15% compared with the 6% decrease in capacity that we had seen in Wales. And so whereas in England, Wales, and Northern Ireland as a whole, there'd been a relative increase in admissions in the over 65s, we'd certainly seen a decrease in Wales. And we concluded from this work that we were seeing a decrease in admissions among the over 65s, those with high comorbidities, those with a medical as opposed to surgical diagnosis, and a relative increase in patients who are fit. So we argued that in comparison with other healthcare systems, including those within the UK even, that critical care capacities failed to keep pace with the needs of an ageing population in Wales. So it's interesting that since then, Welsh Government has invested in the provision of care to patients who become critically ill, and in particular has put some effort to try to separate surgical and wider critical illness pathways within hospitals and the development of post-anaesthetic care units. And this is something we would therefore like to revisit the impact of this investment within critical care. Anecdotally, this is starting to make a big difference to us, but we want to see how this will affect the critical care population that we're admitting. The last of the three studies I want to demonstrate, to refer to, is essentially a study that looks at healthcare utilisation. So we've looked at admissions, we've looked at long-term outcomes, but if we can provide the best care that we can in hospital and during the recovery phase, potentially we can really make some impact here. But as a baseline for this, we wanted to look at healthcare utilisation following critical care admission. So we looked at essentially a decade's worth of admissions to critical cares. We found that in the year following ICU admission, there was an increase in GP attendances, outpatient appointments, ED attendance, and overall hospital length of stay that was more obvious amongst older populations, more obvious amongst those with high morbidity, and amongst those from the more deprived areas, and that exceeded the healthcare utilisation compared with a sample of hospitalised patients in Wales that didn't require ICU. So this is helpful background and leads us nicely to some of our future work, which in the last couple of minutes I'll reference. So one of the streams of work we're undertaking at the moment is to look at the potential impact of critical care follow-up services. There is variability in this provision around Wales, but most of the health boards within Wales provide a critical care follow-up service, which looks to evaluate how patients are recovering from their illness and to coordinate care, whether that is medical or therapies based. So we need to find out how many patients have actually attended critical care follow-up clinics, and how this reflected case mix and how they've utilised healthcare services following ICU. There's been a degree of regionalisation of critical care in recent years, and in 2017 there are 3 designated cardiac arrest centres, so Cardiff and Swansea and Glan, Clwyd, which is where I work. And we want to find out to what degree the centralisation of post-cardiac arrest care since 2017, how has that impacted? So what are the outcomes, and what are the long-term outcomes, and to what degree do these outcomes reflect processes of care and case mix? So that's the second stream. And the third stream on the referencing severe respiratory failure, again, the potential need for very advanced organ support in the form of extracorporeal membrane oxygenation for severe respiratory failure. There isn't a Welsh ECMO centre. The ECMO centres are all in England at the moment. The potential demand for ECMO appears to be increasing, and hence we are having new centres being set up, and most recently in Bristol in 2022. What we want to establish is what is the potential scale of need in Wales, and how might we anticipate the demand and requirements. So our current approach is that we want to be able to identify patients who have been transferred from Welsh intensive care units to ECMO centres, want to see how they compare with a wider group of critically ill patients with severe respiratory failure, and to estimate their respective outcomes. So just to summarise, what I hope I've demonstrated is how we've integrated critical care data with other data sets to provide a useful platform for analysis, to describe the context with regard to critical care strategic and service development priorities in Wales, and to describe how some of these longer term outcomes and healthcare utilisation data can add to existing reporting processes, and then just to provide a few pointers into how such work might inform future Welsh healthcare planning and delivery. But I'll stop there for any questions. Thank you.